Hi there, Neil Docherty here from the Diabetes Complications Research Centre and the School of Medicine and Medical Sciences at University College Dublin. I'd like to present to you the current series of 4 review articles which arise from a symposium entitled Physiological and Pathophysiological Signalling Between the Gut and the Kidney, Role in Diabetic Kidney Disease. This symposium was held at Experimental Biology 2014 on Wednesday 30th of April at San Diego. The session provided a platform for investigators interested in the gut-kidney axis in health and disease to discuss how increased understanding of this axis may be most optimally exploited in the refinement of pharmacological and surgical approaches to the treatment of diabetic kidney disease. By way of background, it is known that physical and chemical stimuli secondary to the presence of nutrient in the lumen of the gastrointestinal tract provoke integrated downstream responses in order to generate a coordinated response to feeding. A focus of physiological research has therefore been to identify the mediators and mechanisms that control the transit, digestion and absorption of nutrient, direct its optimal utilisation, and dictate the activation of central pathways involved in the regulation of ingestive behaviour. Neural circuits and the actions of enteroendocrine hormones are implicated in all of the above. Many examples can be drawn upon to illustrate the action of enteroendocrine hormones. However, the incretin effect in which an oral glucose load elicits a stronger insulin secretory response than an isoglycemic parenteral bolus typifies enteroendocrine hormone-based organ system level coordination between pre-absorptive events and post-absorptive events. A sound rationale exists for exploring the extent to which coordination exists between events in the GI tract and the kidney. Studies revealing the existence of direct communication between the gut and the kidney in relation to ion homeostasis, for example in relation to sodium and phosphate handling, have substantiated the existence of a gut-kidney axis in normal physiology. Consideration of how this axis may be most optimally harnessed in cases of pathophysiology represented the central focus of the symposium. Volker Wallin and Neil Docherty describe how hyperglycaemia acts as a pathophysiological stimulus for compensatory growth of the renal proximal tubule, targeted towards increasing renal tubular glucose handling capacity. The mechanisms are described through which this initial compensatory response becomes maladaptive via enhancement of proximal tubular sodium reclamation and the promotion of early glomerular hyperfiltration. The paper subsequently discusses how the incretin hormone glucagon-like peptide 1 may be renal protective in DKD through mechanisms beyond the enhancement of first phase insulin secretion and improved glycemic control. With relation to this, a description of the direct and indirect natriuretic effects of GLP-1 which target early tubular sodium absorption follows, along with reference to emerging data demonstrating that GLP-1 can exert direct anti-inflammatory and antioxidant effects in the kidney. As circulating GLP-1 levels are restricted by dipeptidopeptidase 4 mediated enzymatic degradation, the potential for DPP-4 inhibitors in current clinical use to have GLP-1 dependent and independent renal protective effects is also discussed. In randomised controlled trials, Roux-en-Y gastric bypass surgery shows superior efficacy to both standard and intensified medical therapy in relation to the treatment of type 2 diabetes in patients with obesity. Accumulating evidence points to the importance of an early and sustained weight loss independent incretin-based effect as a key mediator of the diabetes resolving effect of bypass surgery. Neil Docherty and Carol LaRue present a review which starts by describing how anatomical alterations involved in RYGB surgery lead to increases in incretin hormone release, and subsequently go on to detail how the benefits of RYGB, or gastric bypass, reach beyond weight loss and glycemic control to include improvements in lipid profile and blood pressure control. Given that hyperglycemia, dyslipidemia and hypertension constitute key risk factors for DKD, multifactorial risk factor reduction through bypass surgery has the potential to be of therapeutic benefit in DKD. Emerging data on this are presented, which in summary show that bypass surgery is associated with improvements in urinary albumin excretion and renal inflammation and preservation of renal function. A hypothesis is developed which describes a role for augmented levels of GLP-1 in renal protection following surgery. A perspective is then given on how these effects may be recapitulated in the future in a non-surgical setting. The focus on mechanisms beyond glycemic control via which diabetic kidney disease may be addressed is extended in the review by Doherty, Godson and colleagues. This starts by outlining a rationale for how novel antifibrotic therapies acting downstream of hyperglycemia-induced TGF-beta-1 may be of value in treatment of diabetic kidney disease. Attention is placed on describing how modulating the bioactivity of induced and high glucose 1 and gremlin 1 and harnessing the effects of the LET7C microRNA may hold potential as a means of interrupting pro-fibrotic TGF-beta-1 signalling at and beyond activation of the receptor complex. Marguerite Hatch provides a summary of integration of the gut and kidney in endogenous and exogenous oxalate handling in health and in experimental models of chronic kidney disease and bariatric surgery. There are two key elements of the review relevant to the overall focus of the series on gut-derived signals and diabetic kidney disease. Firstly, a series of animal studies are described which demonstrate that in the context of reduced renal function, the propensity for hyperoxalemia to develop may be ameliorated by angiotensin II dependent oxalate secretion in the distal colon. Also described is the potential for bypass surgery to drive an increase in urinary oxalate excretion and thereby promote urolithiasis, a phenomenon that can be attenuated at least in animal models through probiotic prophylaxis with oxalate metabolizing Oxalobacter formigenes subspecies. When considered in their totality, the articles arising from the symposium support the potential for gut-derived signals to drive resolutionary responses in the kidneys of patients with diabetic kidney disease. In the setting of surgical interventions, these need to be carefully managed to avoid the propensity for counterproductive gut-kidney signals to exert a negative influence. I hope that you enjoy this series of review articles arising from this symposium. Thank you.